to get to see what it was. So like, we're all just I've been married for 24 years. My gosh. Yeah. So it's nice for me. I'm not really worried about little kids or anything like that.
I have a 1-year-old and a 3-year-old, and my 3-year-old, I've been gone for the.
Yeah, because they're recording already and they're running late at 11, so you're good to go. Yeah.
Am I supposed to use this?
Clicker, mic, unless you're gonna stand here and then.
If I stand here, I don't have to use the mic, is that what you're saying?
No, I think you still have to use this. But you can walk with your clicker if you'd rather.
Is it on?
That works.
Hello, all right, here we go. All right, everyone, I know that some of the sessions have been a bit behind today, so we are going to do our best to keep everybody on track.
Yeah.
So, yeah, I'll ask you to just settle in for the moment. We'll go ahead and get started. So of course, this morning's session is attempting to explain the landscape of redesign, of case management redesign in Colorado, if you will. And so let's just dive in. Okay, so why is this the topic at a housing conference? Well, as I'm sure most of you know, many people who need neuro-inclusive housing will access some type of public support. And for people with intellectual and developmental disabilities, most of those supports are provided through the case management system. So that's kind of the entry point into the service system for most people. Excuse me. And in case you didn't notice, but most of you who have interacted with our system probably did, our case management system in the state has seen some really big changes and significant challenges recently. So our goal for today is to help folks understand these changes and how people with IDD will access supports moving forward. So I don't know if anybody else is a fan of home renovation shows. I'm a huge fan, and who doesn't love a good before and after? So we're going to try to use that as sort of our theme today. So as you can see, this house is like, pretty livable. It might be a little bit, outdated or a little kind of, rough around the edges a bit. And they're getting ready to do construction on it. So this is sort of our before image of Colorado's case management system. It by no means, in most people's opinion, I don't think it was like completely fundamentally broken, but there were certainly some things that many stakeholders saw needed to be updated. And so that was sort of the beginning of these discussions. So before the changes that Kidron's going to talk more about in a minute, there were different state entities that provided case management services. And so depending on what population they were looking at or what program they were serving, you either went through a community-centered board, and there were 20 of those designated around the state, covering every geographic region. And they provided both case management and, in most cases, also direct supports to people with IDD. And the programs that they provided case management for are listed there on the slide, with maybe the exception of CHIRP. I don't know. We never clarified. I can't remember if they did it for CHIRP before or not. And anyway, you forget so quickly once things change, right? So then if you had a physical disability or you were not part of the intellectual and developmental disability population, you most likely were getting your case management services from a single entry point agency. And there were also notably 2 community center boards who also were set for part or all of their region before these big system changes. The CCB and SEP regions didn't always overlap. So I'm going to show you mostly just for benefit of sort of having these as a reference point after, but the 2 different maps. So this is a single entry point system map, and these slides came courtesy of Department of Healthcare Policy and Financing. Thank you, Kidron. And then here's the CCB map. So I'll just kind of go back and forth. You can see the colors, the regions are not exactly the same. So if you want to look into those more later, I'm sure they will have the slides available for you. So why was there a need for change? So conflict-free case management, as it's termed, was a long time conversation. There were concerns about a conflict of interest existing where providers of services also developed a person's service plan for services, right? So you sit down with your interdisciplinary team of professionals and family members and other advocates that you want there, and you talk about what services you may want and need. And then if that agency who's developing that service plan and deciding, if the case management entity that's helping decide the amount of services that you're getting is also providing those services, there's a potential for a conflict of interest. And so this requirement for conflict-free case management was actually forecasted by the federal Centers for Medicaid and Medicare Services in regulations for the Money Follows the Person rebalancing demonstration in the early 2000s. I can't recall exactly what years those came out, but at any rate, it's history. And so there were stakeholder concerns on all sides as discussions started around these, and the discussions went on for probably well over a decade, maybe close to 2 decades. So advocates and non-CCB providers had concerns about fairness in how a person selected their provider. Right, the concern was that if everyone is going to, I'll just use the example of community center boards because that's who I represented. And I forgot to introduce myself at the beginning, so why don't I just do that now? So my name is Ellen Jensby. I'm the public policy director for an organization called Alliance. And Alliance represents IDD service provider agencies, as well as many of the existing case management agencies that exist today. And we also previously represented all 20 of the community center boards. And since these big shifts have happened, some of those have no longer decided to be designated as community center boards. So it's all kind of different now. But at any rate, that's who I am and the perspective I'm coming from. So providers who weren't part of a CCB were concerned that if everyone was going to the CCB for their entry point into services, that the easiest choice for them would just be sort of to not have to shop around a lot and go with them as a provider as well. And so there were concerns around that. There's also desire for people to have better access to all available programs. So as I mentioned, depending on which waiver you were going to access, you might go to a different entity, either a CCB or a SEP for case management. And there was a desire to have sort of one entry point for all of the different waivers. So that if you, for some reason, even if you had a developmental disability, for example, you actually would get better aligned services on the elderly, blind, and disabled waiver. They wanted to have that case manager know the options and be able to help you navigate that. And then there was also concern in moving away from the CCB model about the existing community awareness of those organizations. They've been around for about 50 years. And so there were already a lot of community connections made at the local level, and people knew, right? People at, let's say, the hospital. So if a mother, delivered a baby with a developmental disability, they would say, you need to call X organization, the CCB, and they'll help you. And so they were worried about losing that historic relationship. And then also there is an interest to maintaining a local community focus. So some states, depending on how their case management system works, there are, big health groups who come in and provide all of those services. So like United Healthcare, for example. And so there was some anxiety about, losing that local knowledge and awareness of what programs existed. What does the housing look like in this rural community? And is somebody at a big corporation going to know that? And then, of course, our CCB members back at that time were concerned because in many rural areas of the state, there weren't a lot of other providers besides them. In some cases, there were no other provider agencies besides the CCB doing the service. And they felt because of their history in the region and their longstanding sort of existence and the way that they sort of grew up from a grassroots origin, that they had a responsibility to provide services to people that they were worried may not be covered if other provider agencies came in, right? They had sort of a sense of responsibility to take care of their local community that they were worried that other external providers might not have. So those are just some of the concerns, and there are many more that I'm not going to cover today, but a little bit for background. So our state started creating a blueprint for change. In 2014, CMS expanded conflict-free case management to all home and community-based services waivers. Actually, all home and community-based services programs, so waivers and other federal authorities for delivering those types of services. And there's a text there if you ever want to look it up. There's your citation. But in short, they said there has to be a separation between the person or entity providing case management and developing the person-centered service plan and that person or entity providing the care. And so that started a lot of stakeholder engagement, even more than we had before. And there were two different pieces of legislation actually passed attempting to get Colorado to the finish line around conflict-free case management. The first would have sort of created an additional layer in our service system that potentially could have created a lot of confusion and additional steps for families who are trying to navigate the system. And so the second bill that was passed in 2021 was designed to sort of streamline that. And that is the law that we stuck with. And it's sort of final end date of applicability was just this past year in 2014. And so our case management system is still a bit under construction, but we're hoping for, eventually a beautiful before and after image. So this is our hope. And as you can see, they made some structural changes to this home. They added some nice windows on the top. They created a much more clear entry point into the system, which I think is an aspect of what these changes were designed to do. So people wouldn't have to sort of wait, do I call the single entry point? Do I call the CCB? Which place do I go to? So ideally, hopefully in the future with education, everyone will know exactly where they're supposed to go. And I think overall, our after image is a bit, more sophisticated than the before image. So the hope is, right, that case managers, even though they're pretty overwhelmed at this point, eventually will have a lot of education about all the different programs and the populations that they're serving and be able to really effectively help them navigate the system. So fingers crossed, we're not there yet, but that is our goal. I think this is where I turn it over to Kidron. So Kidron.
Good morning, everybody. My name is Kidron Backus, and I'm the Case Management Operations Section Manager at the Office of Community Living. Pleased to be here today. I'm here to kind of just talk about in that blueprint and the decades that Ellen talked about, years and decades that led up to case management redesign. What we did not have in our blueprint were some really big things that happened not only in Colorado, but worldwide. One of those things was the public health emergency. As we know, we all went through COVID the last few years, and as the nation and the world came back from COVID and we had the public health emergency unwind, is what we call it, where in Colorado, the 1.9 million people that are on Medicaid in Colorado were starting to go through the financial redetermination process for the first time in several years. And through that, we had an alignment of our system going through case management redesign and our case management agency transition plan to take from Colorado the 20 community-centered boards and 25 single entry points into 20 designated service areas for case management agencies. That timeline unfortunately coincided. We didn't anticipate it, but guess what? We still had to do the work in the same timelines. And we also, in the middle of this, we were implementing a brand new caring case management program, which is our IT system that allows case management agencies to do all the work that they do. I see some familiar faces from our breakout session an hour ago, and when Carly talked about all of the assessments and the service planning and the responsibilities that case management agencies have, they use this IT system. And just like the outdated house that Ellen showed, our IT systems were outdated. They weren't completely broken, but they certainly were not going to help us have the vision of case management that we wanted for our future. And unfortunately, the launching of that care and case management system also happened at the same time as our case management agency transitions and our public health emergency unwind. And so I'm just here to, call out the elephant in the room that it's been tough. It's been tough for members that are in Colorado trying to seek services. It's been tough for members that are going through that financial redetermination for the first time in many years. And it has been extremely tough on the case management agencies that have undergone case management redesign and those transitions. There is an enormous amount of work that was done for agencies that were not going to be case management agencies because they did not end up with the agreement with Colorado to be under that contract July 1 of this year. And so there was a lot of emotion, even because some of the folks that had been doing case management in Colorado for over 50 years were no longer going to be case management agencies anymore. And so how are we as a department really calling the elephant in the room and trying to be supportive and making sure that we can get to that finalized product of that home renovation? And like right now we have all the things in place. We've had the blueprints, we've done all the work, and probably from the outside, it like on the inside, it's still being finished, and on the outside, maybe we're still waiting for painting to be done, or maybe we've had a little bit of a delay in getting some things from a contractor. Maybe we had to get something shipped in, like new windows, right? And so that's where we're really at right now. But even with all of the emotion and all of the turmoil and unexpected things that we did not see, and the alignment of these three things happening at the same time, we still had very, very key things that as the department and working with our stakeholders, we really wanted to make sure that we looked at the 5 key components of what we wanted to see as those outcomes. This is the representation of what that beautiful house looks like. Number 1, we've got to make sure we have that federal compliance. We need to make sure that we're in compliance with our federal partners so that we can continue to operate those waivers. And we want to make sure that there's quality. Right now, it may not feel like there's quality across the state. And so we're definitely working with our case management agencies, lots of time with the department to make sure that they have the tools that they need to be successful, and that we're looking at things within our system. I mentioned PHE unwind. This not only affects our case management agencies, but it also affects and impacts our county partners. They're seeing unprecedented work doing financial eligibility applications. And so really, how do we as a department support people doing this work so we can have that quality? Simplicity is 1,000% just really what we want in the state of Colorado. Love Ellen's pictures, that house with the beautiful entryway. I actually came to the department after years of experience working at a community-centered board, experience as a provider and as a case management director. And some of the things that we saw every day as a challenge was, as a CCB, people coming to us, but somebody not being eligible for those IDD programs. And nothing feels worse than saying, I'm sorry, you've called the wrong person. I can't help you. Call this number. And now what we have, even with its rough patches right now, what we have is that those case management agencies in those 20 designated service areas where you should be able to reach someone my colleague Amy is here to talk about how that will all happen. You should be able to call them and say, here is what I need help with. And you don't have to call somebody else. You don't have to call the single entry point if you happen to call the wrong person. So we want that simplicity. We want stability. We're going to get there. We're absolutely going to get there. And we're going to be able to provide amazing case management services to the almost 90,000 members in Colorado that receive long-term services and supports. One of the other things that we will also be able to get to is accountability. We're the agency that has the responsibility of oversight for these programs. We're accountable to our federal partners, we're accountable to our legislation and to our governor. And we need to make sure that the programs that we're providing and the case management that we're providing, that we have a really good core system of accountability. When we have more simplicity and we have better quality, we have an easier path to accountability. So this is also something that really just is a visual for you to kind of see that vision of case management in Colorado. You'll see things like conflict-free case management on here. Again, that's the whole reason that 20 years ago this work started in conversation in Colorado. And as of July 1st of 2020 or 2024, it's great to be able to say that as a state, we are in compliance with those federal requirements. It's really great that we have that. And we've really tried to do it in a way that acknowledges that local knowledge in Colorado. Colorado is a very, very unique state. Our landscape is different. Our communities are different. I've lived in rural Colorado my whole entire life. What works well for people in rural Colorado, and we're talking, I'm closer to the Kansas border than I am Denver. Okay. So when I say rural, we're not talking like Bennett, right? We're talking La Junta, Colorado, if you know where even that is. So what works for people in Powers, Otero County is not what works well for people in the metro area. And so how do we make sure that we set up case management agencies to still have that local area and expertise? We really want to make sure that no matter what our new structure is and where we're at today, that we have that local knowledge and expertise. And again, accountability is also what we're most excited about, in being able to be really good partners with our contractors and making sure that we have that accountability. And with that, I'm going to introduce you to my colleague, Amy, who is from a case management agency, and she's going to talk about some of the nuances of how the case management activities and responsibilities work after case management redesign.
Thank you. As Kidron said, I am Amy Becerra, and I work for Rocky Mountain Human Services. We're one of the case management agencies in the Denver metro area. And I should go. So here is a list of all of the new case management areas and by region. I wish I had the quick toggle to show you. Just thought we'd highlight that. So we are in the designated service area 6. I always have to remind myself if it was 5 or 6. And so we are part of the Denver metro region. And so we've talked a lot about the house metaphor and that single entity that will provide services. Just by way of some context, I did start 20 years ago talking about all of this at the Division for Developmental Disabilities. And I know that there are other familiar faces with me in the room that have been a part of this trajectory. And I find myself today at one of the case management agencies. So it's been an interesting path and journey. But we are all committed to making sure that people get the services they need in the community of their choice. And it is our role at the community center board, at the case management agency, to make sure that that's happening in what has been described by both Ellen and Kidron, and our goal of that streamlined process between
intake, eligibility, doing outreach, being part of our community. That's kind of one I want to show here. So whether you are a CCB or SEP, and now you're one of the CMAs, we have been embedded in our communities for years and decades and 50 years. And so we really have been woven into the fabric of our community. So even though there's been a lot of changes, we talk about the before and after, for a lot of people, it doesn't feel much different. There is, thank you for pointing out the elephants in the room, but people still know that our providers know who we are, law enforcement knows who we are, the hospitals know who we are, schools, the county human services, the RAIs. We are kind of that hub for long-term services and supports. And I know this conference specifically is focused on those with intellectual and developmental disabilities. And so we've really been a part of that community for a long time. And we have that case management expertise as part of the new, shinier version. There's improved standards for case management certification and making sure that you can get the same level of case management, whether you're at this CMA or this CMA, that we're all cohesive in providing that. And we have those long-standing community partners, and a lot of us are here today. I actually was the mill levy director when I came over from to Rocky Mountain Human Services and participated on the steering committee for what got us here today, the Neuro-Inclusive Housing Summit. So it's really great to be here. So as we said, we want people to be able to come to us, and this is just represents a little bit of what you should be able to experience coming to any CMA in any of the regions across the state. That from the point of referral, you will receive support to get to the services that you need that'll best meet your needs. And as Ellen talked about, specific to housing, this will be even your entry point there, right? As we talked about, and in the opening session, I was a big part of, Cindy and I both participated on those steering groups and the surveys. This is a complex system. And regardless of how you want to get there, you're probably going to have to go through this process. So we get lots of referrals and we get people pointed in the right direction, make sure that they have the right applications with the county completed, getting their disability applications, their financial eligibility, options counseling. What are your options? That's one of the benefits of the house model, is that you may have an IDD and you may be able to get better services through the EBD waiver. And so helping you understand what programs are available and get you enrolled into those services. That's kind of the front end to get you to the point of case management. And then in the ongoing case management, they'll work with you to get providers in place and services set up, and that ongoing support where you get an annual service plan, at least one in-person visit a year, and a quarterly contact every quarter with your case manager to stay connected and make sure that you're receiving the services and supports you need. So we have 2 waivers for adults with IDD. We have our developmental disability waiver, our long-standing developmental disability waiver that provides access to those residential services. So some of those housing options for, and Cindy's gonna talk about those a little bit more in detail, but this is what provides access to that 24/7 supervision through residential support. So access to host home providers, access to group homes, or apartment living with paid staff. And the big piece that we're highlighting in all of this case management redesign is that conflict-free case management and that individual choice of a program approved service agency. And then SLS is the other adult waiver that does not provide the residential services, but provides supplemental supports so that you can remain in your home, that you may not need that 24/7 support. And so how do the CMAs and the PASAs work together now? So we're conflict-free. I would venture to say that most of you experienced a conflict-free environment before, but we certainly wanted to mitigate the risk that there was that conflict. And so our job is to make sure that every individual has their choice of providers. but we also recognize that the people we support need support. And so we as the CMA balance providing the appropriate level of support in provider selection with what the person needs. And so we always provide a list of all available providers that are there, and a person can either self-select from that list. We see in our former SUP programs that most of the time that they're in a position where they want to self-select. And then in our former CCV or the IDD programs, they are often looking for additional support. And so we have the referral for providers process. It's a organized way that we are able to send out information to all of our program approved service agencies regarding the individual seeking services, what their needs are, what they're looking for, and then we can get responses so that that person can have can go to that choice. And again, with that, our goal is to make sure that they have the individual choice while balancing that supportive role. Now I'm going to turn it over to Cindy on the flip side of that. She's going to get our RFP.
Great.
So my name is Cindy Opheim. I am the CEO of Cottonwood Community Alternatives. We are a provider agency, previously FASA. We're changing our names and acronyms for the new rules and regs. And we have been providing services in the metro area for over 35 years. And so as you're looking at that new redesign and new transition for individuals coming into services, Amy had mentioned when somebody is looking for a provider, either with SLS or the DD waiver, they can either self-select or they go through a referral process. And so referral process takes what you're interested in, refers that out to provider agencies. So for home and community-based services, provider agencies are currently certified through the Colorado Department of Healthcare Policy and Finance. And that's specifically for the waiver they provide, as well as the specific service within the waiver. So you may have someone who's approved for SLS services, but they may only do a few of those services under that waiver. Or for the DD services, you might have someone who provides residential, but doesn't do day programming or transportation. So going back to the complex system, sometimes your case manager really needs details for individuals of what they're looking for to get you to the right provider agencies and get the right services. Provider agencies are also required to comply with any and all federal, state statute, rules, and guidelines. This is where there's that accountability piece to HCPF and HCPF to CMS, as well as through those CMAs. Provider agents are responsible for individualized service provision defined in your service plan that your case management agency helps you develop. Specifically, since we're talking about housing, residential services and supports, RHSS, is covered benefit under the DD waiver for home community-based services. It provides service, support, supervision 24 hours a day, and it provides staffing that's adequate for the person or access to staffing that's adequate for the person. So you might have somebody who has 24-hour supervision in their home. You might have someone who's independent and has access to 24-hour supervision with drop-by checks from a staff. RHSS services are required to provide and ensure health and safety, welfare, training, habilitation, individual supports in typical day-to-day activities, personal hygiene, mental, social development. They're designed for each individual's needs, and they also need to address any medical and healthcare services that the person needs on a day-to-day basis. IRSS is your individual residential habilitative services supports. So IRSS services can be provided in a wide variety of communities. This can be owned, lease, and provider controlled settings. It can be a family setting, which has been discussed in a couple different sessions, and that's family caregiver. A member's own setting, so somebody can own their own home or can be the leaseholder of a setting in the community, or a host home, and that's where you live with someone else who's contracting with a residential provider. IRSS settings support no more than 3 members in a setting at any given time. If you're supporting more than 3 members, you're now moving into a group, which is a GRSS, Group Residential Habilitative or Support Services. And these two are typical homes in the community But it's anytime you're supporting more than 4 people and you're under a different waiver as well as different licensing to run a group home. To the whole residential housing and affordability support piece. So room and board is established every January by the department. So this is healthcare policy and finance. And there's a uniform amount every January 1st that's used that is basically the Social Security income amount minus what is allocated for personal needs funds. So the standard room and board amount that a provider can accept every single month cannot exceed what is set on that January 1st date for the full year. So provider agencies cannot charge a Medicaid member more than the department's annual established room and board amount. And this includes food, meal, basic furniture, linens, utilities, and basic toiletries. So room and board is not just your rent, it encompasses a lot more than that. So Medicaid waiver dollars cannot be used for the provision of any room and board. So when you're looking at service provision and room and board, they're completely separate entities. If a provider has a provider-owned setting, they can only accept the established amount by the department for every single year that they provide that, which we'll talk about in a minute, is not very affordable. So you guys have heard this, that Colorado is really facing a crisis for adults with IDD. There's a significant amount of individuals unaccounted for or on waiting lists or looking for services. A higher percentage that are living with aging caregivers, aging family members. And this is going to end up in kind of a housing crisis, right? Because you're going to have a lot of providers and a lot of individuals who are needing services and a lot of emergency crisis sort of situations that we want to make sure the system is prepared for and get people into settings that are of their choice and that they can be supported in. So a couple of issues that we have looked at for barriers to neuro-inclusive housing. Obviously, one is affordability. So the reason I put that room and board slide up there is because our current SSI income, this is for 2024, is $779 a month. So this is to go to rent, food, utilities, linens, everything you've got going on at your place. Average cost of living in Colorado right now, $2,432. So that's a significant gap. It's a 3 times gap, right? It's not a few $100s. For some people, it's significant. You may have people that it only is $100 gap for, but you have some people that it's a pretty good barrier. Low income housing options. We've talked about some different 811 properties and that sort of thing that address a significant number of at-risk populations for low-income housing. And what we're hearing is, first of all, there's waiting lists. And a lot of times for people with IDD, there's safety issues there because there aren't those kind of supportive amenities or access to enough of an in-complex or in the community provider to keep them safe for those day-to-day things or to safely socialize with the people who are also being served in those populations. Disconnect and confusing system with limited housing and lifespan navigation resources. So you may have one entity that helps with one thing, one that helps with another. So with the case management redesign, right, the hope is that that pulls that all into one entity for someone to go to and get assistance with. And hopefully we'll see an improvement with that. Again, because we've got so many aging caregivers right now, we have a lot of families who need some assistance with doing planning for long-term lifespan services and support so that we can eliminate some of those crises that occur. Housing voucher options. In Colorado, there's limited education access and some pretty extensive wait lists for those. And we know that there's been some mention of attaching a voucher to the DD waiver and that sort of thing. And that is a fiscal note probably the state of Colorado could not ever support. So it sounds like a fantastic idea and a great solution to the problem. But the system's going to have to rethink that and come up with something in between to sort of get that fixed. There also are neurodiverse families who want to invest in housing, but they don't know how to acquire, how to sustain home ownership for people and what those options are. So some more education and support around that. would help to avoid those crises and get people into affordable housing. So there are some current housing support options out there. So I want to talk a little bit about those. They're limited and there are still some complex systems to get through as well as some wait lists. There is the public house authorities. And so these require assistance from your CMA to get involved in. This is where you get your name on a list for a housing voucher. And it used to be that you would go to your CCB, who was also your PHA, and they handled the counties that you lived in. And now PHAs are widespread. They're not necessarily with the county you live in. You can apply for multiple PHAs. And I'm not sure that families and individuals understand that. So working with your case management agencies to find out where you need to apply for housing assistance is the most important thing for people who are not going to be able to afford rent, food, and utilities moving forward. There is also DOLA, which there was a presentation on earlier, who does manage most of the vouchers that are housing choice vouchers that travel with the person, not the 811, that's a little bit different. But vouchers that travel with the person, they have 8,000 in the state of Colorado. This is for people with disabilities. Nothing is IDD specific right now with those. They coordinate project-based vouchers, which are vouchers that are in a setting. So the person can reside in the setting and receive that affordability and housing support. But if they move, the voucher stays with the setting. They also partner with healthcare policy and finance currently for some specific vouchers that are for IDD individuals. And this is through a federal Money Follows the Person program. These are for individuals on SLS who can use a housing voucher to stay on the SLS waiver to avoid a crisis and being having to move over to the DD waiver, which supports that residential. So if your only crisis is money, affordability, then you can apply for a waiver, continue with your supported living services that keep you independent in the community. That helps pay your differential of your rent and room and board. Also looking at a DOLA also is doing a new program where they're inspecting host homes. HCMF is also taking a look at whether some of those SLS or emergency waivers could be used for some DD individuals who might be forced to move to a more restrictive setting and not live independently because of just affordability, right? So if you have someone who's living in their apartment, they've been there for decades, they work around the corner, church is across the street, parents are down the road, and the only thing that may cause them to have to move to a group setting or a host home is a couple $100 a month of rent, they're going to look at whether that program can expand to those. Last legislative session approved an additional 800 vouchers. Again, for the voucher total, it is not IDD specific right now, except for that small amount that HCMF has worked with DOLA on. Good. We just got you're almost out of time. So we'll go to questions next if anybody has any.
Anybody, yeah, you have people with severely affected by their medical needs. And then there's the people who look neurotypical but need help. And like, how are you recruiting people? Because no, don't tell me call my case manager. My case manager says, when you find somebody, let me know. We'll sign them up. Like, this is not working.
Yeah, so a lot of times when you're looking at recruiting somebody that you're going to actually pay waiver dollars for, you want to work through a program agency. Right.
They haven't found anybody. Let me know when you find somebody.
Yeah. And I think the difficult thing with 24/7 care for somebody is there is not a waiver that pays for it one-on-one. The dollars aren't there to support somebody. So when you're looking at those inventive things of like a live-in aid to come live someplace else and take care of somebody, you do run that risk of if the person says, I can't do this anymore, all your services are gone because you have all 24 hours invested in this one person. A lot of times, I think that's why families look at host homes, because the setting is the host home provider setting, and they're doing it as a business. But if somebody wants to live in their own setting, they're right. Yep. Go ahead, Jess. Okay. I don't think it's a question. I think she wants to address.
No.
Oh,
What are we gonna do with individuals who truly need one-to-one support, whether that be for medical issues or because of behavioral challenges, life-threatening behavioral challenges, low hyper, self-injury, all of that. Is like, how do we move forward with creating what we need, a solution, right? Is that happening on the lines? Is that something that's going on in terms of policy discussions? Can the CMAs kind of say, hey, all that?
You don't want to take it.
if I had a magic wand, I'd love to take it.
Right, seriously. So yeah, great point. I think, as Cindy mentioned, current state of Colorado's funding for public supports does not typically support a 1-to-1 staffing ratio in any program that we have, unfortunately. So ultimately, the solution to that is to go to the legislature, lobby for funding to be able to do that. For those who may not be aware, Colorado's budget is pretty restricted. One of the major hindrances we have is Tabor. I'm not going political here, but it just keeps the size of our government funding smaller than it would be otherwise, right? So instead of using all available taxpayer dollars that we have coming into our state coffers to fund public supports, we are sending some of those back directly to taxpayers in the form of checks, right? Everybody loves to get a check in the mail. I'm no different, right? But that's the reality of what's happening in our state. And so this coming budget year, things are looking pretty dire in terms of the budget. We're already in a major financial hole, billions of dollars, like tens of billions of dollars, or sorry, tens of millions of dollars up to potentially over $1 billion in the hole for the next state fiscal year, just based on the programs that we're funding today. So we're actually in an environment where the state is going to be looking at probable budget cuts in the next budget cycle, which starts on July 1st. So that's where we are today, just for a little bit of kind of background and setting the stage for why we're at where we are in Colorado. I think within Alliance, our conversation over the last few years, especially with COVID, has been how do we maintain and protect the programs we have, right? It hasn't really been an environment of talking about how do we expand, how do we ask for, more money for all these things. We still have a significant several thousand person waiting list for the DD waiver. We can sort of go back and forth about the reality of that number, right? There's lots of different nuances to that. But there are people who are sort of waiting in the queue to get what we have today. So it's sort of a sense of like, where should we put the priority, right? Should we prioritize funding the people who are waiting for what we have today? At what point can we talk about expanding beyond that? That's sort of my initial take.
Getting all this intake, so they're gonna be talking to the seniors, and then like, how can we use the CMAs? That did not come out right.
Leverage.
Leverage, thank you very much. Leverage that type of data, and I'm saying this collectively, like, I no answers, but like, it seems as if we're kind of on a time crunch to figure something like this out. It's gonna cost us a lot more money if people are living in hospitals, right? Versus
The people who should have been in care end up in the prison system because they did something that everybody said, oh, they should be doing that.
So what's the role of like the CMA in reporting back is kind of, I guess, what I'm interested in.
So let me take that. So when we were discussing that simplicity and that like doorway into case management, one of our core outcomes for case management redesign is actually speaking to exactly what you're asking about. Like, how do we have case management agencies that through the lifespan of somebody that has those significant disabilities, that the case management agency is going to be there through the lifespan of that member. It's not going to be, oh, you like maybe use the community-centered board for them when they're youth, and then maybe the single entry point and an adult waiver, et cetera, and there's back and forth and there's complexity there. We're really hoping and have that vision for the outcomes of members that have those lifelong disabilities, for them to have that case management agency that can support that member through their lifespan. In addition to that, just general vision and those key outcomes for case management redesign and going into the future, Department of Healthcare Policy and Financing, we contract with other partners, specifically the regional accountable entities. The regional accountable entities have a contract with the Department of Healthcare Policy and Financing that dig into the data for members that have complex needs. And so they have some work that they're doing and trying to gather data. And then just in general, Department of Healthcare Policy and Financing, we're a pretty big state entity, and there is constant work being done to look at those types of questions, like where are the gaps still for members receiving services, that, especially that have the most complex needs, right? So where do we have those gaps? Where do we still need to spend our time figuring out the data, to Cindy's point with some of the costs of services, et cetera. Like, how do we try to get from being in a reactive nature of just trying to, like how do we get from being in the reactive nature to the future, all within the, like, our budgetary situation, right? So just, I can't give you like, it's this person or this agency, but our new IT system will give us better data than we've had before. It's one system where case management agencies used to use, or it's been so long, so how many logins do we used to have? I don't know. So one system that also has the ability, when it works the way we have designed it, connecting with other things like with the county, et cetera. So better systems that are going to give us better data, working with our other partners like the regional accountable entities, having better case management. So we're providing case management through the lifespan of people with complex needs. And then just as a state entity, trying to figure out where those gaps are, how do we move in the future, and how does it become more proactive, even more than we have right now. So light at the end of the tunnel, hopefully. Okay.
And lunch break.
And lunch break, yes.
Yes, so our procedural point, lunch service has officially started. So, people, I don't want to like cut the conversation short. So we do have food. If you forgot what you've requested,
Thank you.
just sort of coded. And people are welcome, I want to encourage people to encourage these conversations.
Yeah.
And there's other.
Yeah.
Question like on the whole conversion or everything. So with the current system.
Actually very curious, like, as a new system,
IT system, give us, IT system is already in place.
You're talking about programs.
The support, yes. Yeah, sorry, this is what.
already she already fixed.
The sixth.
So you're getting that yes, we are able to roll out our new care assessment.
Yeah, right.
Their budget experience on this. And so until we are able to attach the sections in our budget, which will be one for everybody and all of those, we would all fund. Whatever is as your funding level, even when we decommission this, when we decommission, it's gonna be, you're new and really, you've never had the system. You're gonna see our new investments, you can determine eligibility, and then you're gonna use it. Algorithm, right now, and that's what you determine your pay rate level. Until we can get everybody on to things really that person. Yeah, you already have your skills and you're already enrolled. Not feeling for the direction.
Okay, good. I mean, I know, I said just around. As soon as we rolled into assist level, we're expecting the caregivers, all that. And like, oh, by the way, we're changing. Like, okay. And what is the kind of information on how conversions?
They're gonna use, data because of the ones that's like, it's an only part of each role that I hold right now. I'm not really need out of serving like phase diversity. So at CSR was maybe we'd experience with assessment. But right now, I would say probably at least for the next year, we won't be able to gather the data to be able to develop the person-centered budget.
Right.
And then become somebody's. So for somebody who's already enrolled, so I would say you're not really gonna feel any differences. You're something because you already have a system, you're already enrolled in the waiver.
Yeah.
And then when it does, like, what are we gonna charge for our complete intention?
What is the most
That there
important?
isn't going to be, I don't know if you're gonna be hard hit with, I used to be a six to like. Yeah, right? That's not. We've done a lot of research already to try to make sure that whatever algorithm we do implement, we don't run people. I'll take the time. And so that matters. There's certain,
But even though that.
services that will be subject to studies, the way that we is right now in our system. In our future system, we're not going to necessarily need that.
Right.
So that are needed now, we're going to actually be
Right.
access to our system. Our state plans and committee for stories. The majority of people need that person or budget algorithm to dictate one of those rates and let's do that. But we won't. Once you got coming.
This is a great question. My son's, I love it. Probably should almost say. I mean, I think that was a whole other thing to go through. And we're like, 6, he's fine at 6. If you set this on 7, like say, and we know that we're gonna do our biggest bang for the buck, and that's our fear, is that, data. And you're not messing things,
Yeah.
It sounds like.
It would be simple if there's money.
I'm an IT person, so.
Right.
Yeah, we're using that we call the care block management system. It's the experience that called to short care. And there's IT software, it's supposed to, state implementation. There's a lot of functionality within IT platform for like clinical care management that we are not necessarily using right now because we're not.
Sure, it's not fixed.
But that is something, that system's already actually being used. It's used right now to document their assessments, document their contacts, document. We have that system connected to some of our larger Colorado systems, totally like asking for insurance and money management. But now we're just
Like totally different.
and like, can we say in our old system,
I tried to get.
No, we didn't talk to them. It was just database, did not talk to them. So now we can talk to them. Like, people go on. And then eventually we're going to come around assessment of the level of care. It doesn't change the level of care, but we're also talking about changing up the system and to ask really detailed questions for that to get staff that the person needs. And how they actually leads to.
Right now it's a near. So the, I know the case manager asked the question, and then it's a narrative summary and they score it. It doesn't like you can't pull that kind of data other than the scores themselves, right? You can't. So it's,
We don't usually need
yeah.
those answers besides.
Good.
And you'll, I would say, when we will assessment, or something that will be much more detailed than probably all the stuff. So, you know, by going first, but it is with the intention to get all of that into the system, and then that way, like, every year, it should be easier.
This is about it.
Nothing's changed in the last year, so we have to go through.
We don't.
Great, thank you.
Thanks for coming.
Absolutely.
Okay.
I'm like, not that I know of.
So, nobody should be in that certain, that's not true,
Yeah.
until we.
Yeah.
That's what I think spearheaded.
But the thing is, we do that. Make sure.
Right.
There's lots of technical legal things we have to do.
Fresh and memory.
But
Yeah, it's really complicated. I'm not an expert, but basically it just means like the public funding pie can be X big, and then once you bring in more tax revenue that exceeds that pie, you have to refund some of
Which
it
is
to
true.
tax.
Like if I, you know, I don't need a check for $200, but like if the college.
Well, I think that's a like the idea, having some limits.
Right.
They're going to get it because, okay, but it's still.
It's like a table.
Yeah, but there's not the day.
This is what
I think it's not the city.
we're gonna donate our table for care. I don't know. What's that?
But there's special projects that come up, like giving license plate.
Let's do this.
Governor Freeman, their best trying to talk about, well, she talked about it as the only. So she talked about it at the Alliance question that they were using.
I was going directly to.
No, but they had carved it out, so they carved out.
Yeah, having to get creative, right? Like just something different. Anyways, I don't know. And I'm just one person, but I don't even have stuff like that. But
Figured out already.
right.
That's right. Nice to meet you.
I didn't really think about.
Because we did
Yeah.
I know there's already.
Yeah.
Well done, everybody else, we all back in here at.
Three. Okay.
Yeah, no, it's just a mess right now with money.
Crazy, you know, but I don't know, maybe I'm silly and imagine that when people that leave, I understand people don't, you know, they don't want to support welfare, people sitting at home like, but we live in Elizabeth,
Right.
we understand that.
Right.
But like, if it was for someone with disability, like, and not just disability, intellectual development, I feel like that's different. Like, people realize they can, so, like, strangers,
Right.
right? Like, have parents.
But they can be a great part of the community, but it's one of those.
So I don't think you want to, and again, that's because I want to enforce it here, like so much. But at what point are we gonna get to, you know, like we only have limited time and money. Considering what legislatively, policy wise, how can we coalesce around something that's really kind of the box? You know, I don't know, because I don't think that voters would spend, I mean. This population.
Yeah, you would think. I can't go anywhere without running into something, you know.
Is that all right?
Yeah, so I had lunch last week with Timothy, McAfee. And, I'm very home experience. Yeah. Yeah. So these are places, yeah, and decided to say something about it. He's like, how do I get funding, and what do I do with everything else, and I thought my grant sort of experiencing. And that's great. I got to know your. And then I was, telling you, waiting, that's what I'm like, Massachusetts. Oh my God, I used to work for, the lady who runs the office, and I really got against it, her against it. I was like, really, Claire, Jones. Yes. Mine works in my office. Yeah.
Small world, yeah.
Yeah.
You know, some people, they have something in their brain, they just don't. So listen.
I know.
Or, I don't know, yeah. You're right, that is it, it really is it's me. Sometimes we can talk your listening. Or you're right, it's another person, and, yeah.
Yeah.
So I've been meaning to connect about something. Like these are because the way to understand for our senior center, community center, are doing this is what's to create a senior community center because they have gotten money. They have to put it somewhere, they have to use them anyways. I'm so pissed off at them right now.
They had something they called the senior community center with trailer that Ese webinar que está haciendo de personas. Y yo soy lo que escucho las yo de lo que
Sure. We're. Oh. Thank you. So like, I just wanted to make sure you hear me, I really ever. Hoping you'll be able to answer. I think you try to live. Line, like, it's not like that. You're not going to. Does it show you your emails? Oh, no, I'm not like in the waiting room, like just saying the roll rains. So you. Yeah, so they have, I mean, we just leave it on the interest fund. And essentially, I'm just going to talk at them and say, the goal, how I can either take it. This training. And kind of go through reminders, but I don't, so like. Make you like, oh, I don't want to go through the whole slideshow. Because really, this is supposed to just be like, what questions do you have? This isn't going on this session. We're not training you today. You should have taken it. So I think we'll leave it here, and if I, depending on the questions that they're asking, then I may have a jump to the next slide, just to have that. But I really. And that's a little tricky. But if you want to get me those people right now, I think that's my plan is, and I'll say this, but we'll only schedule for 15 minutes today, so we'll be ending because I have to present at 2 o'clock here at this. And this one, like, we may even end earlier than that, because truly, I'm telling them, like, this is not a comprehensive training. you should have taken your training in ELS. This is an opportunity to ask questions for clarification, and I will do my maybe an overview of like, remember what you should have learned in the training and just explore, this stuff, and then see what kind of questions they have. And I'm hopeful that the other people from the department who are supposed to be here will also be able to answer questions. But I am going to try and say, like, we have our stuff. Like, these are the ones that I might have about, like those screenshot ones, and then try to get somebody in the team to be like, I'll pull the system up. And be live demo in the training environment. I think so, it's like. At least we have a couple of slideshows, other slides that have screenshots on them, if they look at.
Yeah, that might have been the people from last. Yeah, and I just talked to Liz, like, she's got that, unless you want to sing that one, she's got this new cover for chat in their center, because I think it's right. Yeah. It should be. Let me shut the door. That would be something, they must have given this, something from bacon. That means we can. It's a really key. And times, folks, make sure you're registered when you got. Which I'll do that. I'm not.
So, London did not have that subject. It's a case manager, supervising the days. This matter is this exception process that we have. It's basically what's in here.
Michelle,
We have made an exception process if
May show up today.
To allow for the opportunity for them to be personal.
You're seeing that for the one family that has like 10 kids. Is it, you know,
So, I called her a couple of weeks ago, and I was like, how do you look? They're talking about they're approving this, and she's like, oh, guys, okay, so we're on the same page. Maybe, are they even wanting us? Because all the kids have like SLS only services. Yeah. Well, they want to essentially build a family compound that they can continue for generation. Okay, we need to go back to them. And tell them.
yeah. I think there's something in those two.
Like, that is, you know, I was not, formula, such a fire. And then do we have to still go back to the same block? You shot yourself in the foot by asking for this exception, because now you're on their radar. And there's no guarantee that they're not going to continue to adopt kids with disabilities. There's no guarantee that 3 kids that are not on waivers are not gonna be on waivers. This is process, because like they're biological children that don't have disabilities are now starting to see family tradition. And it was like American women to rescind their application. No, last waiver. Yeah, we're gonna get much, no, that's last waiver. But as soon as someone's on that DD waiver, they're out. It's done. And so she met with the family. And they are considering it. And they are going to get back to her on whether or not they can continue the process. And like, go along. I can tell you right now, if it comes back to us, the answer is no. And there is no appeal process.
Yeah.
Like, it's a joke. I checked it with her last week about it. I was like, hey, wow.
Yeah, I remember
that.
that.
Absolutely. You know, I started talking about that last night, and I brought my next. And one of the things that someone has been potential. So many people from Boston oversight over meetings coming to this and fighting me. I would like to do that this morning. No, not at all. It was really good. So see people second. But one of the responsibility and the tasks set for the department of that bill, the standardized contract language. And really, I know how they want us to do it since we've offered up the option to the AG's office of a template. Well, we don't really think the template is necessary. Like, how is we going to have standardized contract language? We're going to put it in regulations. You have to say this in your contract.
We can do that.
Yeah. So I have a meeting with.
And we don't have contracts with, items like the consent agencies,
So I have a meeting with Kate County tomorrow to go over this. I'm like, if you want us to address that bill option, but you're telling us that we don't need to do a contract, which I didn't have.
Right, not tell you that, what's in your
brain. Yeah, right. Gosh, okay.
It's the.
You can stay in here. I'm gonna take a break outside.
Okay, enjoy.
You're not jumping into that meeting. Okay.
Not once they get done here.
How are you?
Can you hear me? Good.
Is today here. So office hours, my name is Chloe Altman, I work here at the Department of Healthcare in financing in our case management division in the Office of Community Living. So thank you guys for coming. Today is Pro Case Management Agency Office Hours session. It's just about 1 o'clock, so we'll go ahead and get started. Don't want to waste anybody's time today, but we've got, I'd say about 90% of the people who registered here in attendance today. Just a reminder, this office hours is for case management agencies. So if you're not part of a case management agency, and you're not doing case management activities within Peak Pro, then this office hours is probably not for you. We'll probably need to get your questions and information answered elsewhere. I do have a couple friends here with me today from the department to join in some of our subject matter experts. So depending on the types of questions that you have, or clarification that you need, I may pass my baton over to one of my coworkers. But as a reminder, and for this, I'd like to see the show of hands. You should be here today for the Peak Pro Case Management Office Hours if you have already taken the Peak Pro for Case Management Agencies training on the learning management system. So do me a favor and go ahead and give me a hand raise or a reaction. A heart, any sort of activity, you can throw your hand up in the air. Show me that you guys have taken the training on the learning management system that went over Peak Pro for case managers. I see a couple hands being raised, not nearly as many as I'd like to see if you're here today. Thank you for joining, but this is not a comprehensive training session. The expectation is that you would have taken a training offered to you as a case manager in the learning management system. Finished that training in the learning management system and then come here today to have some office hour discussion, clarification, potentially be able to ask you a question. Okay, if you are just joining, I'll just ask one more time, put your hand up, give us a reaction there.